and welcome back to Phoenix Concussion Recovery Podcast with Concussion Talk. Nick has us coming back today to talk about Persistent Postural-Perceptual Dizziness, or 3PD, which is a newer term for chronic dizziness. Thanks for having me, Nick.
Oh, thanks for coming on. And that's a new 3PD, and I wrote my little post the podcast. I wrote just chronic dizziness, so I gotta change that now because 3PD. What's it? Persistent
Postural-Perceptual Dizziness.
Persistent postural-perceptual dizziness.
Mm-hmm.
That's way
or
better.
Chronic dizziness.
Yeah, well, persistent postural perceptual dizziness. Right?
Mm-hmm. Yep.
Okay. First, though, before you get talking about that, that sounds very interesting. I'm gonna thank our sponsor, Head Check Health. Head Check Health bridges the gaps in concussion care through simple and powerful technology. You can join organizations like the Canadian Football League, Tech Factory Racing, the Canadian Junior Hockey League, Eastern Washington University, and Volleyball Canada, who rely on Head Check Health to improve their communication and optimize care. If you visit headcheckhealth.com, you can find out more. So, with that out of the way, now I will get Lauren. You can talk about postural. One second. Postural 3PD. So 3PD.
That's right. We always make things easy in medicine.
I know postural perceptual. Positional. Postural. Persistent. That's the one I didn't forget.
Persistent
persistent.
Dizziness.
Persistent
Or
postural.
triple PD, 3PD.
3PD is just too easy though. So anyway, before this podcast, Lauren and I forgot a bunch of other stuff too about on the unrelated subjects, but about groups of animals.
There's groups of animals.
Groups of animals, but we know what I'll call it now. Not all of them, but anyway, not 3PD, but all Lauren good 3PD. So Lauren, please tell us and teach me about 3PD.
So chronic dizziness has been around forever, and it's had a ton of different names over time. But there's this group of people, the Béarnais Society, who got together in 2010 and started looking into consolidating all these terms.
The Béarnais Society?
It's I believe a French word, Béarnais. It has little accent aigus over the A's. But so 2014.
Is like BERNIER?
BARANAY.
Okay, well, D is way off. Right. Sorry, go ahead.
So in 2014, they all got together and they consolidated on this 3PD term. So they got rid of all the other old names like chronic subjective dizziness or phobic postural vertigo, and they came up with this one name. And then it was actually added by the World Health Organization in 2017 to the ICD-11. So it's now an official code in the ICD-11s. So it's becoming more represented in the research.
What are ICD-11s?
Any type of injury that you have has a specific code, and the World Health Organization comes up with a concentrated way for all of us to communicate the same. So like in concussion, it would be S06.0, and then it would be a different last three codes depending on if there was a loss of consciousness or not, or if it was an initial injury or a long-term injury or things like that. So the it's just a list of diagnoses basically.
Okay. All right. Thanks. Okay.
But it's a big deal when something gets added to that list. So basically, now that there's an actual ICD code for it, there's a name for it, they're starting to do more and more research because it's a huge problem in the vestibular world, and I believe especially with head injuries, and we're going to talk about why that is and all the triggers that make someone go to chronic dizziness, but you can see how they overlay with concussion and other types of TBI. So people who have chronic dizziness, it's really important that they know that they're not alone. So a lot of times these patients are afraid of their dizziness. They feel like they're just not getting better. There's no answer for them. You really have to seek out a provider who's done extra work to look into these types of things and how to treat them, because there's very successful but specific treatments that need to be done for people with 3PD. So 1/4 of all people with any type of vestibular incident will develop or start to trend towards 3PD. So if you had an episode of vertigo or other types of injuries, 1/4 of all people are going to have that transfer from acute to chronic dizziness even after their initial injury resolves. So let's say you had vertigo, BPPV, and then you got treatment for it, but you still had that fear component. Even though your BPPV has resolved, you could still have chronic dizziness because of this change to the 3PD. So as we go
Okay.
through it all, it'll make sense why that
Okay,
happens.
because you're explaining the transition from acute to chronic.
Mm-hmm.
Because I had after my brain injury,
Right.
I've had double vision, so and I figured that's the major cause of my dizziness.
Then people
You'll explain all that. That's part of that. That would include that would be including in.
Yeah, for sure. And people
Okay.
with traumatic brain injury are going to have layers. Part of the problem whenever we start to talk about TBI versus traditional vestibular disorders is that that patient group is always going to have more layers. Like for you, you have your cranial nerve injury, so you also have a vision problem.
Mm-hmm.
So now you can't even use some of the strategies that you would to compensate for vestibular loss. So I
Mm-hmm.
think that as soon as you start deviating away from traditional vestibular and into the head injury world, the water becomes very murky and it becomes a lot harder for them to do research on because you can't isolate variables as well
Right.
when people have all these extra layers.
Right. That makes a lot of sense.
So it's really common. Like I said, it's 1/4 of all people. But what's even more fascinating is that when they looked at what's called a tertiary clinic, so an outside clinic that treats vestibular conditions, 15 to 20% of all patients that were admitted to those facilities qualify for these old terms, phobic postural vertigo or chronic subjective dizziness. So 15 to 20% of all patients in a vestibular clinic are going to be trending towards or diagnosed with this 3PD diagnosis. So it's really common. It's important that the number one piece is this fear component, so people understanding that they're not alone and that there are treatment regimens being formed that are very successful for fixing this problem.
Okay.
So there's 3 key factors. So when we talk about some diagnosis in medicine is a diagnosis of exclusion, meaning we make sure you don't have a whole bunch of other things and then we just label you as something else, like fibromyalgia, for instance.
Right.
But and people might argue with me about that, but that's how I personally feel about fibromyalgia. But when we talk about 3PD, it is not a diagnosis of exclusion. So it's really important that it's not that you're being labeled something because your provider can't figure out what's wrong with you. There's actually a really explicit criteria that you have to meet in order to be diagnosed with 3PD. And you might have 3PD and other diagnoses at the same time. So there's a lot of overlap with this one. There's a lot of psychological implications with this one. It's not easy and cut and dry, but once you start to figure out the patterns and you understand the diagnostic criteria, it becomes more simple to figure out. So there's the 3 key factors. So part A is the most important. They have to have one or more symptoms of dizziness that is non-vertiginous in nature, meaning that they are not spinny dizziness. I sit up in bed in the morning and I get the world spinning. That is not 3PD. That's probably something else, most likely vertigo going on. So they'll have unsteadiness, they'll feel lightheaded, they'll feel like they are sort of dissociated or floating or foggy. They can't really describe their dizziness. I don't know, I just feel like I'm moving on a boat when I'm sitting still. I am, disoriented when I'm walking. I feel like my head is floating off my body. So they're going to have these weird symptoms of dizziness that they can't really describe very well, and it has to be most days for at least 3 months. So they're kind of saying 24/7.
Okay. So long
So
term.
it's long term, more than 3 months. If someone comes in the clinic and they're 6 weeks out, right? They're only a month and a half out, but
Yeah.
they've got all these signs, you could say something like trending towards 3PD, and you could still treat them the way you would treat them for 3PD, but they can't be labeled 3PD until it's been 3 months or more.
Right.
And it's going to wax and wane throughout the day. So it's episodic in nature. So this is a person who's dizzy basically every day, throughout the day, doesn't really know what their triggers are, doesn't really know how to describe their dizziness, but it's constant. I'm always dizzy. I'm dizzy just sitting here talking to you about my dizziness. That's the kind of
Okay.
things that a patient will say to you.
Okay.
Part B is that the symptoms have to be persistent but without a specific provocation. So this person says, I'm not really sure what it is that triggers my dizziness. And then as you start to talk to them more, you can help them figure it out. The number one trigger is usually exposure to visual stimuli or complex visual patterns. This is the person that says, I really struggle in the mall when it's busy on a Sunday. or I'm really struggle to go down an escalator. I don't know where to put my feet. They might say that when someone bumps into them, they get really an exacerbated loss of balance, right? So these people are really challenged on busy carpets. I went to the hotel and I was trying to walk on that crazy carpet they use to to hide all the dirt, right? And I get dizzy when I walk on that type of surface, or transitioning from tile to wood or things like that. So they're going to have a lot of visual input that triggers their dizziness. It's going to be a lot of the time in low risk situations. So when I'm standing up, I'm just standing there watching someone hang a picture on the wall, and I can feel myself swaying. So that upright posture is a trigger for their dizziness. And then active or passive motion, but without a direction dependence. So if you have a true loss on your right side, if you have a hypofunction on the right side, you're going to tell me that you're dizzy mostly in a directional dependent position, right? But these people are going to say, it doesn't matter if I'm turning left, if I'm turning right, if I'm bending over, if I'm looking up at the ceiling, if I'm sitting in a car, I have the same type of dizziness. So they'll get dizzy just walking up and down a hallway. They'll get dizzy riding in the car as a passenger. They just say it's all the time. It comes out of nowhere. I'm always dizzy. So that's part B. And then part C is that there has to be a triggering event. So it doesn't really just crop up out of nowhere. You can always identify, or almost always identify, what that precipitating event was. The majority of the time, 25% of the time, it's an acute or chronic vestibular syndrome. So I got an inner ear infection and I had damage to my right vestibular nerve, and that has become a chronic problem over time. Or I had vertigo a month ago and now I'm dizzy all the time and I can't figure out why. 20% is going to be migraines, and that is one of the most common coexisting diagnoses. So there's the precipitating fact of migraines, but then also, like I said, there's a lot of overlap with these people. So anxiety and migraine are going to be the most common coexisting diagnoses as well.
Okay, but not they don't cause like a migraine or anxiety won't cause the dizziness. It'll just coexist.
No,
Can it?
both. You could, yeah. So 25% is going to be these acute or chronic vestibular problems. 20% is going to be migraines. 15% is going to be anxiety. 15% is going to be TBI and whiplash. And then the remaining 10% is like autonomic problems, which we actually talked about in our previous podcast. So go back and check out
Yeah,
autonomic
dysautonomia.
dysregulation, dysautonomia. And then there's 3% left over, like arrhythmias and drug reactions. So the majority of them are going to be our TBI population, anxiety, migraines, and then the traditional vestibular people. But also, people who have 3PD will also have a high coexistence of migraines and anxiety. So those migraines and anxiety can trigger, or they can also just be a coexisting problem at the same time. So it gets really kind of murky, and you have to make sure that
Yeah.
the person treating you is looking at you as a whole person, not just looking at you in a box.
No, I can see how that would be like, because I feel like when you were saying part B is where I feel like the visual cues is where my double vision. That's why I find, and I find part C. I don't really find much of the, but I do have a TBI. I don't find much of just regular. I don't like headaches or anxiety, which I
Mm-hmm.
normally don't have, but I do have a TBI, so I'm kind of within that. And when I change, like I said, like in part B, like you were saying, like when I change, well, not it used to be worse when I changed surfaces, and when I turned my head like to look left, that'd be worse. But this will be I'm more part B. I have symptoms part C and part A, a bit, but yeah.
So
So,
you wouldn't technically qualify for
but I
3PD
don't.
then.
Yeah, no, I don't have it every day. I'm not like
Mm-hmm.
I do get it every day when I do those tricking events, but when I turn quickly or something. But I don't like. I'm sitting here talking to you now. I'm not dizzy,
Right.
and
and
yeah, so
and you have to have all the parts. So there's
all that.
actually five different parts, but the top three.
Okay.
But it's the dizziness throughout the day, waxing and waning. That they have this non-specific provocation. They had a triggering event of some sort. So you have to fit each box in order to be diagnosed with 3PD. So
Right.
that's a great point, right? Because you do have some dizziness, you do have vision
Yeah.
problems, but
Yeah.
you probably don't fit the qualifications for 3PD because you're
Right.
missing some of the key boxes.
But as with regards to concussion, CBD concussion can cause it or be an important coexisting factor.
Yeah, so for part C, what's the triggering event?
Yeah.
15% of all people who have 3PD, their triggering event will be their TBI.
Right. Okay.
So you had this acute injury
Yeah.
of either a vestibular problem, migraine, anxiety, TBI, and then for whatever reason, you transition to this chronic dizziness even after the pathology has gone away. So what happens with these people is they have this precipitating event, and what should happen is they're in this heightened alert, using high risk strategies, they shorten their gait, they walk a little more safely. We treat them, the problem goes away, and the person goes off into the sunset on their white horse and enjoys their life, right? That's the
Yeah.
normal, that's 75%. But one
How long generally
quarter,
is this treatment? What? So
um,
you get to that after, I guess.
yeah, treatment for
What?
3PD, the research is varying right now. I
Yeah.
have one study that I'll quote at the end when we talk about the
Yeah.
approach, but they don't, they're starting to build, but you have to have been dizzy for 3 months before. So it's not like it's
Yeah.
a short process, right? And then people
Yeah.
have developed a
Exactly.
lot of bad behaviors in that amount of time.
Yeah.
Um, so the people will have this acute issue, and then the actual problem goes away, but the person stays, their nervous system, one quarter of all people with these issues, one quarter of all people will have 3PD, and those are the people where their nervous system stays on high alert and overly sensitive even after the pathology has gone away. So they had this BPPV, the BPPV has resolved, the vertigo has resolved, but they are still having this dizziness because their nervous system has stayed heightened and alert. So these people will have gait problems, they'll have excess arm swing, they'll have more of a shuffled gait, and it's worse in low input situations. So if they are balancing on a Dynadisc and doing a high level activity, they'll actually use more appropriate strategies. But when they're just walking, particularly in a busy environment, you'll see them kind of shut down and they'll be phobic, they'll be fearful.
And the dyne disc is a physio, like swivel disc. Is that what dyne disc is?
It's like a little a plastic disc filled with air. But yeah, same thing if they were on a
Okay.
swivel disc or if they were on a
Okay.
BOSU. So the higher difficulty the activity is, the better they'll do with their balance. The lower difficulty the activity is, like just standing or walking, the worse they're going to do proportionately with their balance because
When they're
they're
not concentrating,
when they're not, and if they're distracted they'll do better.
focused. Yeah.
So one of the techniques you would use in the treatment is to use high levels of distraction. So I'm going to have you stand here with your feet together on a firm surface with your eyes closed. These people will sway all over the place. They'll be using their arms,
Yeah.
totally inappropriate strategies. They're very fearful, phobic. And then if you distract them, you'll actually see their postural reaction start to normalize. So there's a big nervous system hypersensitivity, anxiety component to these people.
So
Doesn't mean that they're
generally,
just crazy and anxious. It's
yeah.
just that that's the way they're wired, sort
So
of
it
thing.
just means like do that and like did the alphabet backwards or something like that, or
Hmm.
tell me like your favorite, tell me your favorite story from your Christmas vacation or whatever.
Yeah. And they're doing some research to see, like, are certain types of distractions more effective than others. I've actually found that even just talking to the patient, like, what are your kids up to this
Yeah.
week? And they start
Yeah.
telling you, they're thinking about something else, and even that seems to work really well. And then afterwards, they get off the exercise device, and I'll say something like, how did you feel once we started talking? Oh, you know what? I felt a lot better. Oh, okay, well, that's a great segue to talk to you about
Yeah.
3PD and how that. So the education piece and how to broach people is a really important skill that we all have to learn as well. So these people have these gait impairments. They're going to have this fear avoidance behavior, and then we get to part D. So part D is that the symptoms cause significant distress or functional impairment. It's not the people who are like, I'm dizzy all day, but you know what? Whatever. I still ski. I still go to school. I'm not having any problems. I don't even know why I'm here. I'm
Yeah.
fine. These are the people who are afraid of falling. They have anticipatory anxiety. Oh no, I can't even sit on the table like that for you because I'm definitely going to get dizzy.
Yeah.
I can't even think about doing that exercise. I went to this other vestibular clinic and they made me turn my head from side to side repeatedly, and
Right.
I'm not going to do those exercises. It's
Yeah.
those
Yeah.
people, right?
Yeah.
It's the people
Okay.
who are fearful. I'm not going to drive my car because I don't feel safe, or I can only drive the car and I can't be a passenger because I get so sick. So it's
Yeah.
these people have this phobic, they have learned, they've been conditioned to what they can and cannot do because they have this distress but also a functional impairment. And then part E, although it is not a diagnosis of exclusion, Part E is that the symptoms are not better accounted for by another diagnosis. So I don't want someone coming in with chronic episodic vertigo. I do my rolls, it goes away. 3 months later, it comes back. I do my rolls, it goes away. That is not a person I should be treating for 3PD. That's a person that I should be getting on a really good independent maintenance program, right? So just because they have dizziness on and off doesn't mean that 3PD is the only diagnosis. So we want to make sure that we're looking at the whole person. We're making sure that their symptoms can't be accounted for by something else, but also they have to meet all of the previous parts. They have to meet part A, B, C, and D in order to be diagnosed 3PD, but you could always say trending towards, and you could always use some of these treatment strategies with someone who doesn't meet all of the criteria. You just can't go labeling people willy-nilly because you can't figure out what else is wrong with them.
Yeah, it's a good plan. Yeah.
So how and why did this happen to you, right? So let's say you're a listener and you are in the quarter of people, you had probably a TBI or a concussion if you're listening to this podcast, and you are struggling, you've been to a couple different providers, and you can't figure out what's wrong with you, and you're starting to think you're a completely insane person, right? And unfortunately, that describes a lot of people that we end up seeing in the clinic.
Yeah.
So there's 3 key factors, and again, this is areas where the research is still growing, right? We were only just labeled in 2014. We only just got an actual diagnosis code in 2017, so this is all new and exciting information. I only just learned about this a few months ago. I mean, we always had some treatment strategies, but now understanding the science makes it make a little more sense.
Yeah.
So the number one factor is these people have this stiffened postural control. So they use these high-risk strategies like we've talked about. They were able to show this on EMG studies. So they showed on these studies that people did better in high-level activities but got dizzy and lost their balance on easier tasks. So I lose normal postural control in low-level activities. They become visually dependent. So there's a shift in processing for spatial orientation. So basically what happens is the patient starts to rely more heavily on visual input than they do vestibular input. The brain learns to just not trust what the inner ear is telling the brain. And so there's only 3 systems for balance, right? Well, that's not really true, but there's 3 main systems for balance. There's your postural system, your proprioception. There is your visual system, and there's your vestibular system. And so if one is deficient, the other 2 have to be stronger. And so we rely more heavily on our visual input, which is why they do so poorly with visual stimulus, busy carpets, things like that.
And that's why long term they're better, they're worse. Or so what's your thing saying? You're saying they're better with, well, they're better when they're distracted because they don't rely on their visuals much, I wouldn't think.
Yeah, and also, so when you distract someone, when you add cognitive loading, they have to use those higher cortices in their brain.
Yeah.
And so you're starting to normalize. If your brain is only focusing on this one thing and it's hypervigilant, if you distract it and you take away focus to something else, it sort of evens the playing field, if you will.
Yeah.
So these people are... and then number 3 is that there is a loss of this top-down processing, which is what we just talked about. So this main computer system, the cortex of our brain, stops modulating the postural control and the visual dependence, or the spatial orientation. So the first one is that we get that stiffened postural control. The second one is that we start to rely on our visual system instead of our vestibular input. And the third one is that we don't have this cortex processing to modulate these other 2 systems. So basically the train goes off the rails and it is just full barrel ahead in the wrong direction.
Yeah,
right?
Yeah.
Okay. And then why that happens, they don't really know, but there's 2 really strong theories. One is this Pavlovian conditioning. So basically the anxiety component. I know that if I do X, I'm going to get dizzy and it's going to ruin my life for 2 days.
Right, yeah.
So I'm going to avoid doing that. And the more that you bridge that, the more that those nerves that fire together wire together. So the more that I am fearful of something or the more that I avoid something, the more exacerbated my symptoms become. So I become conditioned to my dizziness, and my brain becomes more effective at feeling dizzy and being on high alert. And then number 2 is that there's actual pathophysiology to explain why this is happening, but we don't know enough yet. They know that there are changes in this firing system in our brain where areas of our brain are not communicating with each other the way that they used to. So we end up with structural changes in our brain and conditioning, which results in these functional deficits and these subjective complaints of dizziness. Does that all make sense?
That makes sense to me. I mean, trying to think of my own situation, but I don't have 3PD. I don't have postural persistent postural persistent
Perceptual.
perceptual persist posture perceptual business. Yeah, postural
3PD.
postural perceptual persistent or persistent. Which one's first? Perceptual or persistent?
Postural perceptual dizziness. So I
Postural
perceive
perception.
myself to be dizzy most of the day, all day.
But when it's persistent though, which P is persistent?
Persistent is first. So it's persistent
Persistent.
postural perceptual dizziness.
Okay, there you go. That's what. See, that's what I'm buying for me getting confused about which one came first. Had the wrong one first. Messed up my whole thing. Is that's lots of Pavlovian thing. I knew I thought
You're never going to get it right now. You're too
re-
conditioned to saying
reacted
it wrong.
reacted to the postural, and then I got messed up, so I couldn't figure out which one came next. But yeah, so I think that makes sense to me, and
So we're
hope
going to keep
people.
moving forward then.
Yes.
Okay. All right. So,
Oh,
60%. So this is the tough part of the conversation because people don't, at least in the United States, there's a lot of stigma still around mental health, although it's starting to improve a little bit. People
there's everywhere. I
feel
think
like, I'm sorry?
there's everywhere. I think there's still that stigma.
Yeah. And
Yeah.
people think you're calling them crazy. You're not. It just so happens that the statistics don't lie. 60% of people who have 3PD are going to have anxiety, and 45% are going to have depression as coexisting issues that we need to make sure we're treating the whole person, or these people won't get better. So the people who are resistant when we refer them for this psychological training, the cognitive behavioral therapy and EMDR, which we also did a podcast on in the past, so you can go
You
ahead
we
and check
did.
out that podcast there to talk about talk therapy versus therapy that has really good research behind it. But basically, it makes sense, right? So this is like if a patient comes in and they're 2 years after their concussion and no one's helped them and their life is completely different than it was before, and you ask them about mood changes and they are embarrassed to say yes, what I usually say to the patient is, well, I would be very concerned about you if you didn't, right? I mean,
Yeah.
your life
Yeah.
has been different for 2 years. If you
Yeah.
didn't have some sort of anxiety or depression around that, that you would be actually very strange in
Yeah.
comparison to the people who are having those additional problems, right?
Yeah. Exactly.
Because your life has been altered. You've been, in this case with 3PD, you've been dizzy and you've had a loss of low level function for at least 3 months or more. And so of course you're going to have anxiety and depression. I don't think that that's a negative. I just think it's a fact, and we have to be open to treating all aspects. There are 25% of people with 3PD who will have no psychiatric comorbidity. Obviously, those people will be a little bit easier to treat because there's less layers, but it does exist. It's a low percentage, but it does exist.
And comorbidity just be. I know comorbidity just be no other pathologies, no other diseases or indications, right? Just
Comorbidity would
seemed.
mean like I have two things going on at the same time. So like I
Yeah.
have heart disease and I have diabetes. So diabetes would
Yeah.
be a comorbidity of heart disease kind of thing.
Right. Yeah.
So
Okay.
they
That's all.
have
Just want to say that.
3PD and they have something else at the same
Yeah.
time.
Yeah.
So there's predisposing factors, they believe. So they believe that body hypervigilance, catastrophizing, levels of anxiety, and there's actually 5 personality traits. People who are more neurotic and introverted tend to fall in the 3PD bucket more so than extroverted personality types. So there's a couple different studies that have been done where they talk about these things, and I believe it was the study by Dietrich and Stab who talk about the personality types. One of the other studies that we learned about this through was Dunlap et al., and that one was from 2018. The study by Dietrich is from 2017, and then there's a study by Popkarov and
Just
et
for
al. From 2018. So there's some really good studies out there now that describe all of this. If we've totally lost you today, but
so there's the socializing aspect to it.
Yeah, so there's people, just like we know, people who are more likely to have long-term recovery from a concussion tend to fit that anxiety bucket, people with a history of ADD, women. We know that there are predisposing factors to different types of diagnoses, and so a predisposing factor for this conversion from acute to chronic, early to long-term with 3PD are people who tend to have these different personality traits. They tend to ride that anxiety line already before they got dizzy. Once they become dizzy, they have this catastrophizing type behavior. They have this hypervigilance. They're the people who kind of clamp down when they get nervous and they stop moving, or they have this
Yeah.
freezing gait pattern, or they stall their movements. So there's some predisposing factors to how people handle things that make them more likely to end up in the long-term boat. But the good news is there's really good research coming out about how to treat these people, what are the best options. So the research is leaning towards a three-pronged approach. And if you do not do these three things, people do not have as good of outcomes. So it's really important that you can get the patient to buy in on all three. Two of them are much harder to get patients to buy into than the one. The easy one is vestibular rehabilitation. So you come in, you see somebody like myself, we educate you about what the disease is. Knowledge is power. So the most important thing I can do is educate you why you're dizzy. Something similar to this podcast, maybe a little bit shorter and more efficient, but regardless, we would teach you about the dizziness. We would start to teach you to trust your postural reaction. So what you'll see is a patient is marching on some foam with their eyes closed, which is actually a pretty dynamic exercise, right? And the average person is going to have some losses of balance. They're going to kind of stagger step a little bit every once in a while. But these people are going to be flailing. Their arms are going all over the place. Their knees are buckling. They're having really inappropriate strategies. And so you start to cue them. Use your ankles. Trust your muscles. I need you to exude some confidence. I need you to believe in your muscles. Okay, as you get close to the edge, can you feel the edge start to move backwards? And so not only are you working on their balance and their postural control, but you're also educating them and guiding them. Okay, and then also we would do our habituation therapy. So there's three types of vestibular rehab, but the habituation therapy is going to be really important for these people because you need to get them used to different types of situations and stimuli. So I need to get you used to, it's okay to unload the dishwasher. I need you to do that type of motion. Let's start with 3 times every day, twice a day, and then let's go to 5 times. So you have to start really slow with these people because they have all this maladaptive strategies that they've built. They have all this fear and phobia. So if I just have you start with 20 reps, the
So
bottom's going to fall out of the bag.
unload the dishwasher. You're gonna unload the dishwasher 5 times a day.
No, but this similar motion, right? So
What are,
do,
what are they
and
eating?
unloading the whole dishwasher might be too much. Maybe you need to unload, a quarter of it and then come back and unload some more of it. So it
Right.
just kind of depends on the person. But essentially what you're doing is you're finding things that trigger their dizziness and you're habituating them to it. You're getting their brain used to it again and building confidence. The two that are harder to get patients to comply with is the cognitive behavioral therapy. Again, we've already done a podcast on that, but it's the education, it's the grounding cues, teaching them about their fear component and how to manage that. And then the medication, and patients are often very resistant to the medication. They don't want to be put on antidepressants. What's important to know is that it's very low dosages. So we're not treating you with antidepressants and then faking treatment for everything else, and we just think you're crazy. We're using these antidepressants or these SSRIs and SNRI. Those are the 2 drug classes, SNRI and SSRI, which have the best research to support them. It actually helps to calm the nervous system. So that's why we're using it. We're using it to assist therapy, and they actually start with half the dosages of what you would use for depression, and you build from there. Often people have to try more than one drug class, so it's not easy. It's usually that you try the number one supported by the research, and I'm a PT, so I can't talk too much about that, but you start with the number one, and then they might try to the second level drug class, and then the third until they find something that works for you. And you have to remember that it takes several weeks for these types of medications to start to work. So you need to have the medication involved, the vestibular therapy, and the cognitive behavioral therapy if you want to have a good outcome. And they had a study where they did these 3 things, and they found a 78% reduction in dizziness with this 3-pronged approach that lasted over the 1 to 3 years that they followed up with patients. So highly successful when you think about these patients who have traditionally been very difficult to treat. They found that it took 3 to 6 visits if you were early on in your diagnosis, and 8 to 12 visits if you had more than 6 months, which makes sense. So, and you're heavily reliant on a home exercise program throughout the day. So it's a lot of therapy, it's a lot of cognitive retraining, and then this little boost of the medication, and people are well on their way with a 78% having a reduction in dizziness long term. So it's a treatable problem. We just have to be really good as providers of figuring out who fits in this bucket and selling these additional therapies to the patient where they might be resistant because they don't want to be put on meds or they don't want to see a psychologist. So being able to really explain to them why their success rate will be so much better if they're willing to do so. So that's
And
3PD.
I think that was a great one. Great, that was a very interesting podcast. And
Right.
yeah, I think it's just also you didn't say it specifically, but it is that you indicated that patience for all people, doctors and clients or patients, however you call them. People who have patience need to just take their time and just realize that will take a while to do all this stuff. The exercises and the medication
Yeah.
will take time.
Yeah, I mean, we've got to just educate ourselves. There's some great articles, like I just listed off. Those three would be enough to get you started. Just really understanding that there's always more. You have to think outside the box, especially in these layered diagnoses. We can't just, oh, that person didn't fit that laminated protocol, so there must be something wrong with the person because it can't possibly be the treatment. We have to
Right.
think about these people in these more complex patterns and how can we meet them where they're at. And then they'll be successful. So if we do the right things for people and people are actively involved in their care, right? This is not a passive treatment. This is not me massaging your neck for an hour once a week kind of thing. This is a very
Yeah.
heavily patient involved activity. But if you take control over your own recovery, you will get better, which is the most important thing to realize.
That's great. Well, thanks so much. Actually,
Thanks.
I have to go back and fix up my description of this podcast for my post on the website. But in the meantime, Lauren, would you just tell us about where people can find out more from your website and yeah, about 3P, about whatever about what you're doing in Phoenix Concussion Recovery.
Yeah,
And
so you can find us on phoenixconcussionrecovery.com. Phoenix, like the town in Arizona or the mythical bird, phoenixconcussionrecovery.com. And we've got our exercise program that you can sign up for and follow the exercise program on there. You can follow me on at LZConcussion, LZConcussion on Twitter. We have an Instagram page, but I'm not very good about posting
you're
to it.
not bad.
Um, so the website, and then of course this podcast, and you can find all of our podcasts through Nick's website on concussiontalk.com, and then we have our own little tab for the Phoenix Concussion Recovery Podcast. So you can go back and check out our dysautonomia or our cognitive behavioral therapy and EMDR podcast if you had any questions about those sections of the podcast today. And thanks so much for listening, and thanks for having me, Nick.
Well, thank you, and thank you, Lauren, and everybody. If you have any questions, feel free to just do it. LZ Concussion at LZ Concussion on Twitter, or on their Facebook page, or even my Facebook page and my Twitter account at Concussion Talk, and I'll get those questions to her. But this was great, so thank you. As always, music at the beginning of this podcast is by Ben Sound. www.bensound.com.